Hey team, welcome to the MMOA podcast. I'm Macy Bolt, outpatient PT and TA with the older adult division of Ice Physio. Have you ever walked into a room with a patient and had them tell you, I blew out my shoulder? Well, I sure have. And today we are going to talk about a patient I saw recently and how we took him from blown out to bulked up with three key takeaways that you can implement tomorrow. Now, when I hear that phrase, blown out, when I first interact with a patient, I usually internally roll my eyes a little bit, but I also see it truly as a challenge for me to figure out where my patient's perceptions are for how their body is functioning. Did they hear that phrase from ChatGPT, from their golf buddy, from their ortho surgeon? Really, it's worth digging into and unpacking because if we can get to the root of this belief that their shoulder or any joint is beyond repair, we can use that in our patient education. I also really like to know if they've had any imaging or not. So we know that imaging is not the end all be all when it comes to correlation with pain and function. However, if someone is coming in thinking that their joint is absolutely obliterated, I for sure want to know what images have been taken and what the phrasing is of those results. I work in a hospital system where radiology reports are released directly to patients without anyone actually having to explain the meaning behind all of the medical jargon and terminology that they are reading in these reports. So this often means that Dr. Google and ChatGPT play a really large role in educating our patient about those findings, which I think is a huge gap in our system. While I will never claim to be a radiologist, I do feel like it is part of our due diligence and our duty as rehab providers to really help educate our patients and help them decode the complicated phrasing and the scary terminology that comes with these reports. We can really make this much more approachable for people and really help them understand what was found in those images that were taken. I also think that there's a very empowerment-based approach that we can take with this, where we don't just tell people what's wrong, but we also educate them about what's unaffected and what actionable steps we can take to help them heal. So the patient that I saw, this was probably the first and most important thing that I did with this gentleman was to reframe things. He came in incredibly confident that PT would be a complete waste of his time and that he was headed for a reverse total shoulder replacement because that is what he had been told. His MRI report was not pretty. It showed full tearing with full retraction of his supraspinatus, infraspinatus, and biceps. He also had significant AC joint and glenohumeral arthritis. And in our first conversation, what I did not do is spew sunshine and rainbows and say, oh, your imaging doesn't matter. It's no big deal. We need to just, focus on these other things. I made a serious effort to talk about the realities of what he was facing. So we talked about the fact that he has a lot of wrinkles on the inside. We also talked about the fact that in no way, shape, or form is PT going to put those completely torn muscles back together. And we also talked about the fact that there are other muscles that are still intact. And those weren't mentioned in the radiology report because there was nothing wrong with them. And so just educating the patient that, there may be tears, but not everything is torn. There are still things intact, like your deltoid, your traps, your lats, that control your shoulder and can really have a positive impact if we can target those areas. We also talked a ton about arthritis and talked about how really we can navigate and manage that arthritis by doing things that are going to help lubricate the joint through movement, and how important strength is for an area that we do know has arthritis. For this patient specifically, because he was such a skeptic, it was really important for me to lay this out for him early on. And by having the conversation and framing it about what we have within our control, I think it really helped him to have a grasp on where his expectations should be really early so that he didn't think I was just blowing smoke, and he knew that I kind of had a plan for where we were headed. Fortunately for this guy, he really didn't have a lot of pain on board, probably because of those complete tears, but he did have some severe functional limitations where Really, neither of his shoulders allowed him to reach above his head, and his dominant arm had about 45 degrees of elevation for one repetition when we started. And if he went for a second repetition, he would fatigue and literally not be able to lift his arm at all. Right shoulder made, just the most gnarly grinding and clunking noise. I truly don't think I'll ever forget the noise that his arm made when he did any sort of movement. So all of this to say, I knew that it was going to be important to kind of adapt and modify the way that we started out with this gentleman. And the way that I did that is by using gravity to our advantage. So our first session really aimed at getting his range of motion improving and working on some deltoid activation. So I had him doing some pulleys, getting him through whatever passive range of motion he could get, some semi-reclined dowel presses with a punch to get a little power built in. So that punch he was doing quickly to try and activate some type 2 fibers and use momentum to his advantage. And then he did some supine snow angels for some gravity minimized abduction. His progress was definitely slow, but over a few visits, he was definitely making some strides with overall mobility. So as we progressed over the next month, we worked up toward some banister slides and wall slides with a lift off, doing some semi-reclined punches, eventually with a 5 and a 10-pound weight held in both hands. We did some weighted shrugs and bent over rows to get a little more posterior chain activation. And then last and certainly not least, the landmine press, which is one of our favorites here in the older adult division. So all of this to say, one thing I really can't emphasize enough is how consistent this patient was, which I truly think made all the difference in our course of care. He bought in. After those first couple of visits, he was all in. Everything I told him to do, he did that and more. And I never had to wonder if what we were doing wasn't working because he wasn't consistent, because he was on it, which was huge for his progress. Ultimately, his goals for PT was that he wanted to be able to work on his collector cars on the lift in his garage. So sustained overhead movement. He wanted to be able to drive without limitation, and he wanted to be able to do basic yard work. So in order to do those things, we needed to continue working on building capacity overhead. And not only overhead, but overhead outstretched, and needed to have more pushing and pulling involved because that was a huge part of the yard work that he wanted to do. So as we continued to progress forward through our plan of care, we really loaded up his landmine presses with heavy resistance bands, had him doing sled pushes, sled pulls in clinic, added variations of deadlifts with high rows to simulate yard work and pulling. And this is really where my patient started to see things come together. At one of our visits, he came in and he was like a kid in a candy store. He was like, Macy, our workouts now feel harder than the stuff that I have to do every day. Like my daily stuff feels easy compared to this. And I jumped for joy. That was like, finding the golden ticket at Willy Wonka's factory. It was just that light bulb moment where he's like, oh my gosh, I am capable of doing the things that I want to and need to do in my life. So we talked a ton about building that capacity, building that reserve so that he could continue long term to do the things that he wanted to do without his shoulder being a limitation. And like I said, the day he shared that with me was when we really, really started to see the scales tip in favor of function. So he has since, he's awesome. This is who I want to be when I am an older adult. He has since created a home gym for himself with heavy dumbbells and a rowing machine and all kinds of other cool equipment. And we laid out a long-term program for him involving upper body pushing and pulling in horizontal and vertical planes, loaded carries, bracing activities to activate scapular muscles, and he is back to working on his cars overhead, albeit not for a long amount of time. He's doing short spurts right now, but is mowing his lawn, he's shoveling, and he's able to drive without any problems. So during this course of care, we did not fix his arthritis. We did not reattach those torn muscles, But what we did do is change the environment in which those deficits live. So we built tolerance through loading through the muscles that were available to us. And we created mobility and control in those end ranges that he had not achieved in years. And in my opinion, most importantly, my patient gained confidence in his capacity again. This final point is really, really the key to what we strive for here in the older adult division. If we can get folks believing in themselves, we are going to see massive changes when it comes to increasing activity and decreasing sedentary time. So my big 3 takeaways from this case are, number 1, we need to acknowledge the known deficits, but focus on what's within our control. If I had just spewed sunshine and rainbows at this guy and not taken the time to explain his imaging or acknowledge that there are indeed internal changes that have happened, I would have totally lost him. On the flip side, if I had said, yeah, your shoulder is trashed, let's see what we can do, that would have also been terrible. So this is where the art of rehab really comes into play, where you have the opportunity to meet the patient where they are at with their knowledge base, use your knowledge base to sprinkle in some hope and really help them see a way forward from where they are right now. Number 2, simplicity was our best friend. So we know that the shoulder is one of the most complex regions in the body with tons of joints, movement variations, and muscles. But by creating a program for him that really highlighted functional movement patterns of a push, a press, and a pull option for most of his movements, we were able to really highlight the muscles he did have available to him and create some significant functional change. In addition, I didn't change up his exercises every time I saw him. When we found something that worked for him, we would tweak variables to increase effort and intensity with what he was doing rather than completely pivoting and totally throwing the baby out with the bathwater every time I saw him. I think that was really helpful in both of us seeing progress. And a really good example of this was with the landmine press. We used the landmine press pretty much from day 1 on. And we started by using his cane and working on just active motion and assisted motion at that. And then we gradually did things like adding bands and adding ankle weights to increase the effort and intensity. And then we changed the tempo and we added some end range holds to translate to some of those more endurance-based and, long lever reaching activities that he had to do for his car maintenance. These tiny tweaks and tiny changes with the same exercise made such a huge impact on his recovery and really kept the process simple. And then my third takeaway from this is to listen to your patient. This for me is always a takeaway. And if I hadn't taken time at my evaluation to figure out what my patient's perceptions were, to listen to their thoughts on how rehab would go, and to really dig into what their goals and expectations were, I would have been floundering with a patient who really didn't want to be in my clinic and didn't think that I would be able to help them. But by taking time, doing a really thorough subjective and focusing on patient education that first visit, I was able to lay the foundation and really build a therapeutic relationship with this fellow who ended up making amazing progress and was able to avoid a more invasive intervention. Thank you so much for joining me today. Head on over to ptonice.com if you are interested in learning more and joining us in an upcoming course, and click the link below to receive our biweekly MMOA digest straight to your email with tons of great actionable clinical pearls. Talk to you soon.